everyone. We're recording this session, so that's why I have a microphone. And Dane will give you a microphone if you're going to ask a question, just so we make sure that we catch it all. Oh, actually, Blaine in the back of the room is going to do that. So before we start, I just wanted to let you know kind of the sequence of events. First, we'll hear from Dr. Christopher Brown. He is our infectious disease specialist here at Campbell County Memorial Hospital. He'll give you some information on the Strep A cases that we have experienced, and then we'll be available to answer your questions. So without further ado, Dr. Brown.
Okay.
Can you hear me okay?
Yeah.
Great. I'll give you a little information about, I think, what happened, and then try to do my best to answer whatever questions you might have. And if I don't have the answer, then we can try to find the answer for you, if we can. In the last 6 weeks, around mid-August to mid-September, there have been 3 cases of Group A strep infection. Now remember, Group A strep causes lots of different types of infections. The vast majority of them are not a big deal, you know, things like strep throat and some other things. Occasionally, it's not terribly common, but it does happen, usually sporadically. Group A strep will cause a serious and even life-threatening infection. So we had 3 cases that ended up getting hospitalized or admitted to the hospital, that came from outside, from the community, got admitted to the hospital, who would meet the criteria for life-threatening Group A strep infections. Again, relatively unusual, usually sporadic. Of those 3 cases, 1 died. And of those 3 cases, 2 were what we would call necrotizing fasciitis. And although the term is not a very descriptive term, it's been referred to in the lay public. People will talk about flesh-eating bacteria. That's not really what happens, but it's been given that term in the public. So that term has been used so people are able to recognize the seriousness. So even CDC or NIH they'll say, well, you may have heard of it as this. So 2 of those cases were that serious type of necrotizing fasciitis. The other case was a life-threatening case that was caused by Group A strep, and that was more what we would refer to as a toxic shock. And that toxic shock term has been in the, I think, in the public over the last 30 years or so. We've heard about that. There used to be a lot of talk 30 years ago when people talked about staph infections associated with tampons causing these serious infections are called toxic shock. So it's a toxic shock-like infection, still life-threatening. So those 3 cases, the 2 necrotizing fasciitis cases were closely linked. Those 2 individuals were hands-on on a regular basis with each other, so we will see that occasionally. Again, that's uncommon, but that is seen. So that occurrence doesn't surprise us. We don't see at this point a connection between the case that was not necrotizing fasciitis and the other 2 cases. Perhaps there's a connection, you know, we're looking into that in terms of the epidemiology of it. That usually takes some time, but we don't see a connection there. In case you're wondering, and in case you'll ask about the dog issue, that was brought to my attention, I guess, yesterday. I believe it was in the paper, one of the papers. And I spoke to the veterinarian. That dog had a necrotizing fasciitis-like illness, which I'm not a veterinarian, but I gather in dogs is pretty uncommon. However, that bacteria was not Group A strep. That was a staph. They cultured it, it was a staph. There was no Group A strep cultured. So our assumption there, and the veterinarian's assumption is, it doesn't look like that dog case is related to these people cases. And we have not seen any further cases, but we would call this gathering. If it had been one case, you know, you'd call it an incidental single case. When you have several cases that occur together in timeline or together in geography, you know, this is a smaller community, then we call it a cluster. That is not an epidemic. This is not an epidemic. It's not expected to turn into anything like an epidemic. It's a cluster, which simply means that you have a sporadic occurrence of several cases, and when you look at the literature, the medical literature that describes this kind of thing, what usually happens is you get a cluster or an individual case. People really don't know where it came from, and it goes away, and that's usually that. They usually don't recur. But in the interest of trying to reassure the community and reassure everybody, the doctors and so forth, there is some epidemiologic tracking work being done, and that means you know, looking into who went where and was in contact with who and that sort of thing. It's not recommended in these situations to do that, but we think it's important, so we're doing it. In other words, these cases, when they happen, were reported to public health. You know, our public health central is in Cheyenne, and the public health offices in each state are linked to the CDC, which is the main organization responsible for looking at transmissible disease, particularly infectious disease. But in this setting, what is required for the toxic shock and for a blood culture that may have strep in it, which we saw, that it's required that you report those. So it was reported by our infection control nurse to the state, and they put it down, they keep track of the statistics. But that doesn't automatically launch you know, further workup or investigation. CDC doesn't say, oh, well, we want this or that. You know, certainly with other organisms it would, anthrax or an aggressive salmonella or something like that. So I hope that gives you some information and background, and again, I'll try to answer whatever questions you may have. But please understand that when we answer questions, we have to respect HIPAA guidelines, which are the mandated privacy laws. You know, I can't break the law, just like you can. So when we talk about cases, we're not supposed to give information that might identify that individual. Yes, sir. Oh, I'm sorry.
Oh, no, that's right. I will, Dr. Brown, I will. Sorry. Hope I don't speak too loudly. The person who passed away, and that's probably all that I can say. Do you know how? Do you know how that individual? I can say that. How they came in contact, or what caused him
to get sick or infected?
Yeah, did they do any background list? Or could you do that to find out what might have caused that?
We are doing it.
Okay.
And the answer to your question is no. We don't know how that patient got that.
Okay.
And when you look at these cases, you usually don't. It's kind of like, well, gee, this is unfortunate.
Right.
But group A strep, that bacteria, is relatively prevalent in the community. But again, it's like it's almost like automobiles. There are you know, there are different styles of automobiles, and there are different styles of group A strep. The vast majority of them are don't do much of anything. Some of them cause strep throat. If you take 100 people in different populations just off the street and you culture their throats, you'll end up, you know, it varies what locale, but from 2 to 20% of those people will have strep in their throat, and they're not sick at all. This same strep. But some of these streps are virulent and bad. So we don't know where that patient got this, but we are doing the epidemiologic work because the hospital wants us to.
Sure.
To try to shed more light on it. And, you know, we may end up in a month or a few weeks after all this has been done, and the organisms have been looked at saying, we still don't know, but we may be able to shed more light on it. And of course, since this has happened, certainly at the hospital, the physicians, the nurses, and certainly out in the community, the providers, you know, believe me, they're all attentive. You know, they're attentive, and that usually the natural course is it happens and it dies out and you don't see them again.
The second patient who had close proximity, can I say that? Because you're going to say,
I think you can say whatever you want.
Well, I understand.
I'm the one as a medical healthcare person who can't. I'm not supposed to, you know, breach.
Okay. I will say the second patient who had close proximity with the person who died, quite ill, and is not in this community right at the moment. Can you say anything about that or not?
That individual is very ill. That individual has not died.
Right.
That individual is not in this community.
Right, yes, I understand. Okay, I guess that's all I have to ask Dr. Brown. Thank you.
You bet.
Dr. Brown, when this case occurred, the first one, was it the hospital that typed?
Yes, ma'am.
Dr. Brown, I hate microphones with passion. Dr. Brown, would you address specifically the tracking that goes on within the hospital in terms of the patients who both were here in-house, the spaces that they were in, if any were shared, and I guess address kind of what the hospital is doing in terms of ensuring that, you know, that there couldn't be a spread here in the hospital?
Well, you know, in medicine and biology, you can never say never, and you can never say always. But the best precautions are followed. To my, you know, when all this transpired, I was out of town. However, having had a chance to review things, to my satisfaction, the appropriate precautions were taken. And in fact, more than recommended, and when I say recommended, I mean public health CDC recommended precautions were taken in terms of offering prophylaxis to close contacts, which is not a current recommendation, you know, by CDC. It's really left up to the individual case and tracking, and so I don't, you know, I'm comfortable with what happened here in terms of the cleaning up and the protection and so forth. Now, the more that's learned down the road from these investigators about group-based strep, might those recommendations change? They might, but that's the future. But as it is now, this hospital, because of the physicians involved, actually went beyond. So I'll give you an example. Of the three individuals, you know, Dr. Neuwirth, Dr. Fort, and Dr. Mormon, there were other physicians involved, but they were intrinsically involved. And they, you know, they did, I mean, it's not many places. Dr. Fort basically spent the night in the hospital with one of these cases. And because I was not here appropriately, he contacted infectious disease in Denver, spoke to them. And he and the Denver infectious disease group discussed the case and actually did more in terms of trying to protect, for instance, hospital personnel than would normally be done. They did an excellent job. Dr. Warman, with the case, you know, her involvement, in my opinion, went the extra mile, taking lots of phone calls on the behalf of concerned family members, helping with selected prophylaxis. You know, but these virulent strep infections are lethal. It is scary. I'm not worried for the community, but when they happen in the individual case, they're quite alarming because they can have a high mortality. The older the individual, the more comorbidity. In other words, if the person has heart disease, diabetes, and lots of other problems and are more frail, the higher the mortality, sometimes as high as 50%, but usually in people that have a lot of other problems. But again, fortunately, they tend to be sporadic. They're relatively uncommon. They sort of come and go, and they're not the kind of infection that, uh-oh, we're going to wait for the next case here next week, or the next 10 cases the week after. It doesn't operate like that. And there's plenty of group-based strep around, but those are the more forgiving streps. Yes, ma'am.
Dr. Brown, using your automobiles as an example, like strep throat would be a Chevrolet, and like the other one that was here would be like a Pontiac, and the one that died would be like a Cadillac? Is this what you're trying to say?
No, let's make maybe the analogy, and I think it's a good analogy. Let's say it's automobiles, and you're talking about racing, right? Most streps are kind of like a Renault, a Chevy Vega, something Volt, they're running around. And then you look at the Ferrari, right, or the Maserati. I mean, really, it's kind of what we're talking about. They're very unique. They're fortunately infrequent. And we know genetically what they look like, thanks to the good work done by people like Stevens and Musser and some of these other people at outlying academic centers. So the technology is now available to match them and track them and label them. And when you can label them, then you can look in the community and make some estimations about, okay, here was the type. Was it related to another state, or was there some contact? And then you can say, well, we looked around reasonably within the community of all these other group-based streps that we sampled. And it'd be nice to say, we don't find this anywhere else.
So it isn't the way your body reacts to it, it is the actual bug.
Those organisms are very virulent. It's the bug. But, the less strong you are, the older you are, the more underlying disease you have, then the more likely that organism can do you more harm.
So it would be safe to say that if you were exposed to that and were in really good shape, if you were exposed to the Cadillac, that there's a chance they wouldn't do anything to you because your body would fight it off?
They're more virulent. They can do me just as much harm as anybody else. What I'm saying is that they can do more harm in someone who's older and sicker. No, they're very aggressive organisms, and I frankly can't tell you whether those organisms, because I'm not sure anybody knows. Looking at the literature, whether I'm sure they can perhaps be colonizing asymptomatically, but that's not usually the way they operate. Yes?
Yeah, Dr. Brown, that particular bacteria is not an airborne antigen by itself. You have to have, I'm speaking from reading what I presume would be the facts in the newspaper, you have to have personal contact, you have to have an open sore, and they have to be the infected party in order for you to get it. Passing you on the street, in a hallway, whatever, is not going to happen as far as me getting sick.
That's informal contact is not thought to be a significant risk. For instance, the strep throats. I mean, they do. Strep passes person to person. You shake hands. You're exchanging, I don't know, toothbrushes or whatever. And, kids can give other kids strep throat.
Okay.
But it's not thought that I suppose sure if somebody is coughing right in your face who is infected,
Well,
the droplets certainly could transmit infection. But again, you definitely want to follow the standard precautions, like in a hospital setting, but the recommendation is left up to the individual as a prophylaxis or not, but it's not a standard, recommendation. So,
Chris, I just kind of wanted to address what Amy had brought up about,
I wanted to address the fact that, people think, well, if you have a good immune system or you're young and healthy, that this is a bacteria that your body will just fight off. And at least in my professional experience, even the young and healthy don't fare real well with it. They may lose an arm, a leg, both, and live. And I think that that's the big difference in terms of people who are older or who have comorbidities, is they don't lose an arm or a leg, or they may lose an arm or a leg and not survive it, where the young and healthy may survive that onslaught. And for me, I think, is that your understanding pretty much of the...
I think that's what I was trying to say. I mean, they're bad organisms. They're just bad organisms. So anybody can get into trouble with them, but the younger and stronger you are, the better able you are to deal with it. So that's kind of a general principle, I think, in medicine and infectious diseases anyway.
Do we want to take a couple questions from social media, Flish? We did see something come across social media asking specifically, this particular person had a strep staph infection in 2001, 2002 that almost killed he or she. How does she or he find out if it makes them safer or at greater risk for strep A?
You mean because of a staph infection? Because they had a serious one?
Apparently that's the question, yes.
Yeah. It's always kind of, it's not always a great idea to speculate on a case where you don't know the patient and have the information, because the way you do it right is you take a history, a physical, you review the records, and do some testing, and then you give an informed opinion. But I think I get the gist of that question, and I don't know the answer to that, but certainly with any concerns that people have, they should call their doctor. And discuss it with them. I'm not sure I know the answer to that question. I think I know what they're asking.
That's fair.
Could you describe, and I know you've said this before, what the general treatment approach is with patients that have this invasive, aggressive strep A?
The bad ones? For all of them, certainly like any serious illness, a lot of intensive support. That usually means these people end up in the intensive care unit. Fluid support, blood pressure support, oxygen, hands-on. And it also generally means, in the case...
I don't have the exact date, but I believe it was the day that the patient died.
Any other questions?
Can we go with the Cadillac again?
Sure, whatever you
Does the
want.
same antibiotic, like if you were gonna use Vanco on the necrotizing fasciitis, are they all sensitive to that? Or do you have to do a culture and sensitivity to figure out which antibiotic to use?
They tend to have fortunately pretty characteristic antibiotic sensitivity patterns. So there are actually any number of antibiotics that you can use that are administered intravenously that are and should be effective. And I mean, they are effective. It depends on what happens. So there, you do have options. I mean, there's some sort of nuance there in terms of this or that, shall we use this one and add this one? But there are a number of them that can be used intravenously that would be effective. But you do, like in standard microbiology, infectious diseases, you do like to try to obtain sensitivities. Yes, ma'am.
I would like to know that, say like at the funeral for the one that passed away, and the other person, people come and offer their condolence. Now, could that have possibly been how she contracted it? And then is this going to cause many, many other people in our community to get it too?
I think we understand how the third case got it from the second case. Those two patients, individuals, were in close contact, hands-on and so forth. One individual was helping to care for the other individual. So that makes sense to us. But still, common sense hand washing procedures, things like that, proper care of a wound, a scratch. It's like with our children, if they get a cut, we make sure that it's quickly washed, maybe put some disinfectant on it, and then same thing we do with our children. If it looks like the cut is becoming infected or getting red, then we call the doctor. But in public, there really isn't a significant risk. Again, you can't say always or never, but there's no significant risk. You're just, going to someone's funeral, visiting their house. And again, most of these cases are sporadic cases, right? It's not common to begin with, and then most of them are sporadic. And then a subset of them, making it less common, right, are those that give it to somebody else. And that's even a reportable occurrence. That's uncommon. That's one reason why this has, raised some eyebrows, is because that happened here. There were two people, one presumably gave it to the other. That doesn't usually happen. It's usually an isolated necrotizing fasciitis, and of course those people have family members, and they're in contact with other people, and it usually doesn't transmit like that, but it can. The two groups of concern, again, aren't casual acquaintances or neighbors or anything like that. They are close household contacts and medical healthcare workers. In the literature, you'll find doctors, pathologists who got sick, died, other physicians caring for people with these problems, uncommon, who have gotten it, have gotten very sick. Some of them have died. So healthcare workers is a concern. Again, standard precautions should be good enough, but there's no always and never. So those are the groups that we think about. But it's, you've heard of meningococcus, the type of meningococcemia, where it can be a bad meningitis. It's a bacteria, and in that setting, if there are close contacts, the CDC will recommend, we think you should give those close contacts antibiotics. With this situation, it's not an across-the-board official recommendation. Maybe it will become one down the road. It's really up to the judgment of the physicians and so forth. But it's not an automatic recommendation. If you ask different doctors, they might say, well, I think I might do it, or I would do it. But if you're looking for consensus, it's not there yet, which means that people feel that it's less of a concern in terms of transmitting, although it certainly can.
You just answered my question. That's what I wanted to know, is that, so second person had an infection, and that's what started this whole thing. Third person was caring for second person, and that's what started there. So it's an open wound that started the whole thing.
Exactly right.
Considering the close contact the third person had with the second person, once they exhibited a blister, did the hospital have concern that perhaps they had contracted necrotizing fasciitis as well in the second patient, or was it only later on did they sort of deduce that this is what this person had?
Oh, no, that was an obvious, they were on that immediately, because that was always, you know, a concern, so. And that, actually all three patients were cared for very immediately. Again, this didn't start in the hospital, it came from outside. They ended up in the hospital, because when you get really sick, that's where you go. But they were all dealt with very quickly and appropriately, but these are bad diseases. So you can do everything that's in the textbooks and you may still die or may still be seriously harmed.
Any other questions?
Dr. Brown, I assume then any family members, whether it's case 1, 2, or 3, that haven't exhibited any signs are not being treated by any antibiotics.
Well, again, that's,
or just checked in.
Like I said, it's kind of, it really is up to the individual physician involved in discussions with those patients, be it a community physician or a hospital physician. But I will tell you from a hospital standpoint, hospital physicians who care for those patients, the prophylaxis that was offered and given was above what would normally be recommended. And actually, that makes me feel good. I don't have a problem with that at all. I like that approach.
I'm talking other family members. They were automatically given antibiotics without exhibiting any signs.
Do you want to speak to that, Veronica?
I honestly don't know about family members. I know that there were a few people that Dr. Mormon individually discussed with that were put on an antibiotic, but that was due to how close they were with one of the patients. But I don't know on the other ones.
We're not really privy to, the outlying physicians, community physicians. I mean, and they're, but these community physicians are, I think they're pretty astute and they pay attention. That's been my experience. So, but again, we're not privy to what they do, and we're not supposed to be. But I know lots of those discussions have been had between family and patients and physicians. And here we chose to do some prophylaxis.
I have another question. How would they be tested? Would it be by blood or swab or?
How would patients be tested?
Or potential family members that have come in contact. Would they have to go in for a blood? I don't know how it's cultured through blood or swab.
Usually, you can carry it in the gastrointestinal tract. That's unusual, and it's harder to culture that. But generally, it's in the throat. So, for instance, some of the survey work we're doing will be throat cultures. Not with the idea that it may be out there lurking, but to try to build a map of. Is there any evidence that it might be there? And can we say anything about movement or where it might have come from and that sort of thing? Might be information that we gather might be helpful to other state health departments. People travel a lot these days.
Any other comments or questions?
I have one
Yes,
more.
ma'am.
I heard the gossip going around, he got it because he had an IV in the hospital. He got one in emergency, and then he got one as a patient. Now, my question is this. If this were true, where did it come from to get in that IV? Was it because the man had it on him?
You mean, I want to understand your question clearly. Are you concerned that it may have come from the hospital?
No, just where did it?
Oh.
Was it because it was on him?
Yeah.
And the IV caused the opening in the flesh, and so there the bacteria crawled in. I mean, that's a weird.
Oh, I see what you're saying, No, that's not the way it works. When these people came in to be cared for at the hospital, they were sick. Their IVs were put in after it was quite clear they had, you come into the hospital, usually through the emergency room, it's apparent you have a significant problem. Rapidly diagnostic tests are done, and the treatments are instituted, IVs are put in. They were having significant problems before any IV got in.
And I had been told this on many occasions, and I'll just ask.
I'm glad you asked, because, yeah, you're right. And that's why, we want to answer as many questions as we have. And this kind of thing, people get cancers all the time, and bad pneumonias, and heart attacks, and this is uncommon, but it does have a very high public profile. Because it does sound scary, even though it's uncommon. Years ago, I remember, I think his name was Jim Henson, the creator of the Muppets. He died of this very same thing, and he was a young, healthy man. And it was all over the newspapers. I remember, I wasn't very old, I think I was high school or something, but I remember, I'm still not very old. I remember that vividly. I wasn't in med school yet, but it was all over the newspapers, and it was all over the talk shows, and it scared people, and it scared me too. And then we recently had this unfortunate woman who lost some limbs, and we're talking about the same thing. But again, uncommon and sporadic. I will tell you that this type of infection is increasing somewhat in prevalence. The country is seeing more of it. But by saying that, I'm not saying that it's an epidemic, and it's not like that. It just over the years has become more common, and maybe that has to do with more antibiotic use. Who knows? But now we have pretty sophisticated technologies to track it. One such, one of the investigators we're working with on typing these organisms from Campbell County was the gentleman who did the quite remarkable study on Canadian organism, where there was a cluster and then another cluster, and raised everybody's eyebrows, and then another. And they couldn't quite get a handle on what was going on until they did the fancy genetic typing. That was in Houston, actually. And they figured it out, looked at the transmission patterns. That same individual is doing our work.
Thank you.
And we don't have the problem that the Canadians have.
Is there a possibility that this could be genetically, a person could be genetically predisposed to having more susceptible to this?
That's a really good question. Those are possibilities. There are, and I don't know the answer to that, but we do know that certain people can have immunodeficiencies, deficiencies in antibody production. Your body produces antibodies. Sometimes there are different conditions where the antibody production is somewhat defective, either mildly or severely, and then there are other immunodeficiencies. That's a very good question, and nobody really knows the answer to that. There are complement deficiencies. It's a great question.
In the tracking studies that are being done, is this a point of consideration?
You may have just made it a point of consideration. I don't think that was intended, but it's a very good question. And what I will do, we'll speak to Dr. Stevens, who's considered by everybody to be kind of the world's authority on this entity. And I will ask him that question because you asked me. It's a good question.
Thank you.
You said that patient 2 presented himself with necrotizing fasciitis was very severe. On August 24th, during the timeline that was released yesterday by the hospital, Patient 2 was admitted for an illness that was not believed to be necrotizing fasciitis, but then had to be readmitted on the 28th. So was it a separate illness that he was admitted for on the 24th, or was it just the beginning stages of necrotizing fasciitis and it just wasn't recognized at that time?
It was a totally separate diagnosis with nothing to do with infection.
Just would like to point out that the young lady that's answering some of those questions is Veronica Taylor. She is our infection prevention officer within CCMH. Just to help you understand why she's been fielding some of these questions. Are there any other questions?
Just have a quick one.
This is more of a personal question for Dr. Brown. Did you, when you came to sleepy little Gillette, Wyoming, ever picture that you would be in the middle of this kind of an infection cluster?
It's my job. I've seen plenty of these cases. Most of us in infectious diseases have seen these cases over the years. And a lot of number of surgeons have had experience with these cases as well.
And also funeral homes.
Yes.
I, as a student, encountered quite a few.
With no other questions, Dr. Brown, do you have any closing comments?
No, other than if you have questions, please ask. And it's important that you get your questions answered.
Karen, do you have anything to say? All right, well, thank you everyone for coming.
Don't forget.